Thanks for listening to the Pharmacy Podcast Network.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hi, everybody. Thank you so much for joining the Pediatrics Podcast in Review here on the Pharmacy Podcast Network. We are really excited to introduce our guest, Lisa, today, but I'm also switching it up. You've seen Mary has been truly down for anything as far as a staff member for Perfecting Peds, so we're throwing her in once again as my co-host since Justin couldn't make it today. So, hey, Mary, say hi, and I'm blessed to have you, my partner in crime for all things these days.
Yeah, literally your partner in crime for all things these days. Well, I'm happy to be here. My name is Mary Vong, and I am the Chief of Staff at Perfecting Peds, and I guess honorary co-host. But happy to be here, and I'm happy to introduce Lisa Lubsch. She's a PharmD who's board certified, and she's a fellow of PPAG. So Lisa, I want you to kick it off with a nice intro.
Oh, thanks, Mary and Jenna, for having me. I really am excited to share with you all the exciting things that are happening in the world of cystic fibrosis. A little bit about me. I have been around a minute, so we don't need to go where I graduated and all those things. I've been taking care of people with CF for over 20 years. That's probably all you need to know. And, where I lie right now is in St. Louis, Missouri. And so I work at Cardinal Glennon Children's Hospital, which is part of the SSM network. And I've been here since 2006, along with my primary position at Southern Illinois University, Edwardsville, which is right across the Mississippi River. It is a pharmacy school that we have been in existence, since 2006. And so I actually have a co-funded position between the two places and the pediatric faculty on staff at SAUE. I am a mom of three. I have a 10-year-old boy, an 8-year-old girl, and a 2-year-old little boy that those of you that are listening know me. His name is Bruno. And he blessed us with Down syndrome. And so my life has forever changed professionally and now personally the last 2 years. But I still love getting these opportunities, to work professionally in my realm of taking care of people with cystic fibrosis.
Oh, thank you so much for sharing that with us. I'm sure it's been the biggest blessing. Although I'm sure your life has changed substantially. We're in the similar throes of life over here with a 7, 5, and 2-year-old. So we
Busy.
just welcome chaos and / thrive in chaos. But thank you for sharing that with us. We're really excited to get your expertise transparently. Perfecting Peds as an organization really has just a handful of cystic fibrosis patients. So I feel like as a pharmacist, for probably 10 years, I really have only seen probably 20 because there was always the specialty clinics that these children went to. So selfishly, this is going to be a huge learning opportunity for myself. So I am really excited to learn from your expertise. So just to get us kicked off, can you just give us for those listening, just a brief overview of what cystic fibrosis is, very simply?
Absolutely. So CF bottom line is that there is a problem with the chloride channel in the body, and the channel really is everywhere. So the defect, which I'll get into in a second, occurs along the cells of the lungs, the liver, the rest of the GI tract, the reproductive tract, the pancreas, sweat glands. And so everywhere in the body, chloride is not moving freely or flowing freely, which would then lead to these dehydrated secretions because water and water and sodium would follow. So people are left all over these different organ systems with dehydrated secretions, really viscous secretions that lead to a lot of obstruction and potentially infection. And so that really is the pathophysiology of CF. If you want to get into the underlying defect, then tell you more.
I think it's honestly such a cool disease if you really think about it, because it affects so many different body systems. So it really opens a door for pharmacists to help and to just make so many very meaningful recommendations. So I guess to start off with our questions, I know the topic of our podcast today was CFTR modulators. So what role does this protein play in the diagnosis of cystic fibrosis?
So what CFTR stands for is CF, transmembrane conductance regulator, and it is the protein that regulates this chloride transport that I was describing. So it is an ion channel. The underlying problem then, again, is, the inability to secrete the chloride, and it's reabsorbed into the cell. And how this happens is an amino acid sequence is deleted off that chromosome that impacts the gene that codes for this CFTR protein. You probably have heard the most common one that's called F508del. So I might be saying that quite a bit. So F508 deletion or F508del is the most common genetic mutation in CF. And this one specifically leads to defective either CFTR production or processing or conduction or regulation. So there are different mutations. What I'm saying is different mutations that either you don't have enough CFTR produced so that it can act as that channel, or it is produced and it doesn't work correctly. And so now we have CFTR modulation with oral medications that work a little differently that we'll talk about, that can help have this channel act normally. It's amazing, the stories I'm about to tell you of some of the people I care for. Yeah.
That's awesome. We cannot wait to hear it. A lot of times it sticks better when we can actually talk about, how it displays in real life. And things didn't really click in pharmacy school until I started actually taking care of patients. So we are excited to hear that. What are some ways that can help the function of this protein in people with CF?
Yeah, so again, highly effective modulator therapy is really called protein therapy. And depending on the mutation that a patient has, they would benefit from either a potentiator or in combination with a corrector. So potentiators work when CFTR is produced, but it's defective. And so a potentiator will increase how well CFTR can open at the cell surface and let chloride flow in combination in some of our therapies with correctors. And so correctors then work for deficient CFTR. So it increases the amount of protein, then in combination with the potentiator helps it work. So that's protein therapy. Another mode of increasing or potentially helping the function of this protein would really just be genetic therapy. And so we can talk a little bit later about gene therapy and the advances that we've made within gene therapy. So, genetic mutation analysis is necessary early on in life to determine, which route or what is indicated for the patient. There is still a good percentage, unfortunately, of people with CF that are not eligible for modulators, and so for the oral therapy that we have access to. And so again, gene therapy is something that is still on the forefront in research for those folks who are ineligible for a modulator, so that until the cure is found, and then that would be the cure.
I feel like that's like I've gone to a lot of CF walks and stuff. Like, it's funny, this is my little secret that CF is my second favorite disease state. Like, epilepsy will forever be my bread and butter. I absolutely love neurology and everything. But if I wasn't a neurology pharmacist, I always wanted to be a CF pharmacist, just because I feel like the impact is incredible. And it's such like a unique group of kids and people in general. So how do these CFTR modulators work, and who can benefit the most from them?
Well, there are 4 current CFTR modulators available. 2 are considered highly effective. So those are the ones I want to spend time on. The other 2 are still on the market. And there's even more research that we'll talk about that are coming. But the 2 that are left off on the market, really have only niche roles anymore and aren't overabundantly used. And so I like to say, not to quote a certain artist, but I am in my hemp era. That's for sure right now, because this is still a newer thing. So the first one to talk about is ivacaftor, which was approved in 2012. So it sounds like a long time ago, but it really isn't when, you've dedicated your career like myself to watch this all unfold, this whole story. And so ivacaftor is a potentiator that works at certain class mutations. There, are 5 different mutations out there. So class 3 and class 4. And again, this is where the CFTR protein is created, and it's at the cell surface, but it doesn't function or open. The channel is faulty, and we call these gating mutations. And so ivacaftor facilitates that chloride transport by potentiating the channel opening of the CFTR protein. So back in 2012, it was approved. And what happens for all these agents is that over time, then more mutations have been added to the label. And then the age that it's approved for has gone down. So we are all the way down to 1 month of age in 2023.
Wow.
Amazing. So how early can I give this? Almost, beginning of life.
Yeah.
And we can't even get all the work done that we need done in that first month of life. So just to lay it out there, a baby's born, they get their, they had their newborn screening, which may have revealed that was, a CF screen. So a positive newborn screening for CF. Those little babies still need to get sweat tested. So that is the diagnosis of CF is to get their sweat test done. This is commonly done the first 2 weeks of life, right? They need to go home, from their nursery stay, because hopefully there isn't much, disease things happening yet, depending on, their course. And then they'll come to get sweat tests from that positive newborn screen the first 2 weeks of life. We'll take blood for mutation analysis, because we are, getting mutation analysis on all patients right now to know then what protein therapy might be indicated. And then that takes weeks to return. So their diagnosis of CF would be made, from their sweat chloride tests. And if those were abnormal, but then we'll have to wait a couple of days to a week for their genetic analysis. So we're already at week 3. And then, it comes to then getting approval for, using these more expensive therapies in patients. And then we're at a 1 month where it's indicated at that point anyway. So the quickest we've done it really is we've started ivacaftor as early as 5 weeks of life. And to have these little, dosage forms to be able to give to these little neonates is quite impressive. One other thing I wanted to mention about ivacaftor, sorry to keep talking so long, is something that is also super remarkable, that in 2017, ivacaftor was given approval for more mutations, not based on human data, so not based on clinical trials in people. So it was able to gain more label extension by doing in vitro data which has now opened the door to very rare genetic disorders that wouldn't have a sample size large enough to do a phase 3 trial in humans. And so subsequently, all the other modulators have also gained more genetic approval, a genetic mutation approval based on in vitro data. And that was the first time that the FDA ever allowed this. Super remarkable. So I'll stop there because I do want to tell you about the triple therapy and its story, but I have spoken enough. Yeah.
No, continue. This is awesome. Many learnings, and I didn't know that ivacaftor now goes all the way down to 1 month of it. And I know we'll talk about that later, but when you think about early treatment, you just think about how much that prolongs their life expectancy, which, again, even I graduated 2012. It was like, if you have CF, you live till 30, and that was a great life. And I think slowly we're starting to push the envelope in the age. And so this is really breakthrough stuff. So I not at this moment, but I love to hear how you think it expands or what you've seen as far as an life expectancy.
Oh, yes. Well, I mean, I can address it now. Right now, we have more adults with cystic fibrosis than children. And that happened like 2 or 3 years ago, where we hit this threshold of there are more people living with CF that are adults than children. And it was something to celebrate. So I'll always present, when I'm presenting my slide, the very first patient registry slide where it says, and this was 2001, where I can go backwards on it. And in 1985, the life expectancy was 25 years of age. And then my first year involved in CF was 2001. It was 33 years. So there were some advancements back then. And then the last patient registry data that we can quote is 2002. It's at 68 years. Now, they do cohort it by people who are born today, and with the advancement of what they're going to have access to, will live normal lives. Wow. In terms of life expectancy. It's a beautiful thing.
I might squirrel for a second, but I've also heard that the CFTR modulators will increase fertility too. So that's one thing that they've been seeing, that like a lot of the counseling has had to be on that.
Correct. Yeah. We have more pregnancy than we've ever had. And so let me tell you about the elexacaftor, tezacaftor story, because that's where this comes into play in terms of like the life-changing benefits that we see. Since ivacaftor is so niche that it doesn't fit a large portion of patients. And so bring us to, 2019, when the triple, modulator became available. So in combination with ivacaftor is elexacaftor, tezacaftor. That was approved in 2019. So adding on the two correctors that actually work together at different sites of the protein, you're getting an additive effect of increasing the amount of protein that is available for chloride transport. Now, I love to teach families because this is the agent that really transcends the majority of patients. So we're talking about 80 to 90% of patients qualify for this particular agent, and where we've now been able to study the disease modification, that in pregnancy is one of them, where the number of females that have become pregnant since 2019 is just growing rapidly. It's quite amazing. But I think it's important to know how, do I talk to families about this medication? So to really get back to how they work, that the triple combination, I look at it as like a doorway. The channel is a door where we want to open the door. And, that tezacaftor and elexacaftor are really our keys to the doors, opening all the doors. And that ivacaftor is the door stop, that keeps the door open when I show them what their chloride channel is, like fertility, to get to the bottom line of this life expectancy business, that it was just presented at the European CF conference back in June that we have real world data out 3 years, and that this triple combination of elexacaftor, tezacaftor, and ivacaftor reduces acute pulmonary exacerbation by 76%,
Wow.
which means hospitalization. It reduces death by 62%, and lung transplant by 86%, along with some other stuff that, we'll continue to talk about, in lung function and infection rate and fertility. So real beautiful things. We're down to 2 years of age for this triple therapy. So it made its way from 12 and above, down to 6 and above, now down to 2 years and above. And hopefully continue to get expanded age approval down to that 1 month.
Wow, that's insane. So I know you alluded to some of this, but what are some of the challenges and limitations of the existing CF treatments and just the general management of CF in general?
So all the previous therapies before we had modulators did result in lung function improvement. We usually use generically FEV1 or the forced expiratory volume in the first second as our major lung function. So I will just say lung function from now on, but I really am talking about FEV1. So a general improvement of between like 5 and 10% predicted in your FEV1 from different lung therapies that we have out there. So, Dornase alpha, hypertonic saline, inhaled tobramycin are more common previous therapies, and they're very time intensive. Those are all nebulized therapies. What we were talking about earlier with highly effective modulator, it's an oral tablet or a granule. So it's much simpler to put into your day. On top of it, something we haven't taken away is chest physiotherapy, also commonly known as the vest, where people will put on the vest and, be on different settings for 20 minutes twice a day. And that is still recommended today. So before modulator therapy, people would spend over 2 hours plus a day hooked up to something, right? Hooked up to the vest, hooked up to the nebulizer, to maintain their lung function. And it just isn't got to be like that anymore. Another challenge prior, pancreatic insufficiency is common amongst people with CF, where we need pancreatic enzyme replacement therapy to absorb anything that they're eating, most anything. And they have to take a lot of capsules. It's a big enzyme burden.
Yeah, it is.
Big enzyme burden.
Expensive.
And so we have time-intensive therapy. We have lots of capsule burden, and that hasn't changed much. But again, we will talk about how modulators are reducing this burden of disease and this burden of treatment. One other challenge I want to talk about, drugs don't come without their side effect profile. So I talked about how, this triple therapy is approved for 2 to 5 years of age. That was the most recent approval in 2023. And it actually has been really hard to institute therapy because they're not seeing disease as we saw in our 12 years and above, where acute pulmonary exacerbation may not be something that they've had yet, or nutritional issues may not be in the forefront for many patients. So to try to sell families on this is my crystal ball and what your life might be like, and we know that this is what life could be like, please take this therapy because we're preventing it from becoming that. You have to have almost like a car salesman approach, which I don't like. I'd rather not have to do that. And what they read online from other families, who are louder about their negative experiences versus those that are sharing their positive experiences make it even more of a challenge. And I won't lie that there is a side effect profile there of some behavioral concerns that did not come out in the small sample of trial for approval, where people are reporting aggression. And so it's really hard to know, is this a toddler-like behavior that you're dealing with at home, or is it a medication side effect? And And so I have new challenges that I didn't have before in my education, about these medicines, on, trying to be a salesperson on top of mitigating any potential concerns that real concerns that people have. Some challenges there.
So I feel like your challenges parallel a lot of our challenges, because I feel like that was one of the biggest lessons I learned starting this role at Perfecting Peds, is like how to put my sales girl hat on. And Jenna honestly is like the queen of that. And she definitely taught me real early on how to like sell our services and how to really prove our worth. So I totally empathize with you that that's a huge challenge. So you're able to touch a lot on your challenges, but what are the most rewarding parts of your job?
Well, I mean, prior to 2019, I was going to funerals. Here's where I will begin emotional speak. There's so many families that I cared for in the hospital. And I say families because it wasn't just, the child in with CF, that my job inpatient was, choosing the right antibiotics and trying to help get them out of the hospital and home and, improve life and hopefully extend life. But that wasn't always the case. And, now it's not like that at all. And we get to celebrate. So, 2019, when we got approval in 12 and above, we call that first clinic visit, the hemp visit, where lung function, FEV1 improved probably well beyond that 10% that I talked about with the other therapies. People felt better. Now, those first 2 weeks of starting therapy in these adolescents and adults, they were moving a lot of stuff, those secretions that were buried down there, those thick secretions had to come out. And for lack of a better word, we called it the purge, which I don't love that word, but that's what we called it. So, they had to go through their purge. And then after that, the way that people would describe how they feel, and being able to eat a meal and not have pain from digestion, to be able to have exercise tolerance and walk to the bus stop without getting winded, to swim in the summer with their cousins, is such a beautiful thing. And so my job has completely shifted from an inpatient practitioner and caring for 10 to 12 children with CF at a time. I'm at a moderate sized CF center, to I rarely have someone in for a pulmonary exacerbation. If a person with CF is in, they're in from some other complication or something gastrointestinal reason, or it's the people that aren't on this triple therapy yet. So, again, it's down to 2 years of age. And so if somebody got a really terrible virus and, ended up with a pulmonary exacerbation, and needed some support with IV antibiotics, then I'm there. But again, my whole position went from inpatient, intensive, busy doing tobramycin kinetics and vancomycin kinetics. And my math is getting rusty today. And I love that. I love that my skill of calculating a volume of distribution is leaving. And that's
Amen.
okay. I'm okay with that. I really am. And I get to see patients and their families now that I've gotten to see them in the outpatient setting. I'm, a part of their life. I'm their CF pharmacist, and I love bumping it. I've bumped into people at the store. I've bumped into moms at concerts. One of our people with CF, our patients, she works at where my kids, take swim lessons. So I get to see her every week. And it's just so fun to see people out in the, real life,
in the wild,
enjoying instead of at home with their treatment burden, because that's not what it is anymore. So it's beautiful. It really is.
Thank you for sharing that. You've, gone through how it's, impacted you in clinical practice, and just how the families and patients' quality of life has improved drastically, even down to things that really, quite frankly, I didn't even know that they were in such substantial pain. I feel like a lot of disease states that are chronic that cause pain, like you think oncology, CF, sickle cell, they're just like so tough, and they honestly stop complaining about it, or they're like our pediatric patients are warriors, and just in general, they complain so much less significantly than any other population.
You just get used to feeling that way, unfortunately. And so your baseline moves, and a lot of it is gut health, or always having a chronic cough. And this is going away. It's gone away.
That's amazing. Can you share just like maybe one of your favorite patients or case where the CFT modulator therapy specifically impacted the patient's life, and disease progression? And then alternatively, I'll also tack on how that affected your life too, and how the impact of you as a CF pharmacist.
I have lots of little tiny examples. I think, again, I love to go back to the teenage years because it was so impactful. And I'm not saying that like the kids that are starting it younger, it is going to be life changing. It's just that, again, they didn't get to experience the pulmonary disease as these teenagers did back when starting in 19. So, there's so many stories of that first visit where we got to see the dramatic improvement, where I get, again, chills just rethinking about this, where one of our patients, she was probably 18 at the time. She brought a beach ball to clinic to say, I've never been able to blow up a beach ball. Never in my life have blown up a beach ball. And she gave it to the physician to say, here's, the first beach ball I've ever blown up. Sports has really been, if you're involved in sports, it was always a good way for airway clearance. But, to get as competitive as you wanted to be, I think, that it really took a lot of work for kids to maybe try to play college sports. So we have college athletes. We have a volleyball player. We have an esport player. I hope he listens, because we have an esport player, which is considered, that he's also a trumpet player. And, I'll never forget, because we also know each other personally, that, when he started learning the trumpet back in grade school, where, I'm sure his mom loved those practice sessions compared to where, fast forward now, again, he's a freshman at Mizzou, and he had to choose between, esports or playing the trumpet and marching band. So meaning he made his way, through grade school to being able to choose between, video games or marching band. And he chose esports, which is amazing. I think, back to the impact for sure, though, is we have 2 babies on the way. So it's back to that fertility discussion, women that I cared for in the hospital when they were children and teenagers are now in their 20s. I've had to transition so many people, which is really hard for a pediatric pharmacist to do.
Sure
Transition and let go of care to the accredited adult center. It's fine. They'll be fine. But, we're talking about marriages and babies. And so these, again, women that I gave antibiotics to and did tobramycin kinetics for, back then are now, pregnant and expecting, and to watch, pictures of their wedding, on one of them, to now pictures of pregnancy is just so beautiful. The final favorite patient, I must say, which hits the theme of our, the podcast really well, is I was able to, I'm highly involved, with the CF Pharmacy group. We have a listserv. We're really close.
How cool.
I was in the first 20 of us, and now there's hundreds of us, including pharmacy technicians. And and so, I've been able to speak there a lot, or, lead sessions a lot. So when we were able to have our first big plenary session 2 years ago, I was one of the planners, and I was able to bring a patient to speak as one of the 3 speakers. And, I picked a patient who I knew had a really good pharmacy story because she had left our center and went to a different center for a couple years because of insurance, and then luckily was able to come back to us. So she was able to understand, the difference between, care. There's differences. And I have a CF pharmacy technician that has been working with me since I think 2018. And, I want to share with you a little bit later on what that means. And so, she's this particular, person with CF, she's been able to then really have a relationship with me and, the pharmacy technician. And I was just told at her last visit 2 weeks ago that she has a pharmacy technician job and, may have aspirations to go to pharmacy school. And when you have a patient, choose, your passion. How can that not be your favorite patient, right? I mean,
it's unfair advantage, that's for sure.
So to be continued in her journey, but I love too that she chose a community pharmacy, so that way, her young 18-year-old self isn't seeing some of the pressures that we get in other settings. I mean, not saying that there's not pressures at the community pharmacy. I think it's just a really nice place to start. Right.
1,000%. I agree. Now that kind of rolls into my next question of what inspired you specifically? What was your hook, if you will, for the CF patients?
Yeah, I have a mentor who, taught me along the way. And so she became my mentor during residency. So I did do my residency at Texas Tech University in Amarillo, and I was really afforded a lot of time in pulmonary. I had no idea when I was getting myself into. I loved asthma clinic, and so I do still take care of a lot of asthma. That would be my second passion here. So exposed, during residency to people with CF. I attended my first bronchoscopy that year.
Wow.
And that procedure, if you've ever seen one, it really is like changing of thinking through what that airway looks like, just thick snot covered, and bleeding, to be as descriptive as I can without getting real gross. I watched a young person die that year with CF, and unfortunately it was in a critical care situation, instead of how I've watched, other teenagers die, in a much less chaotic environment. And so it was a hook, of there's a lot for me to do here. As you said earlier, Jenna, that it hits so many organ systems. And so it's not just the airway where I have an impact to be made here. I loved pharmacokinetic monitoring and I loved doing math. And so I do miss it quite a bit, that I don't get to do it as often. So doing that for the first decade of my career and owning, kinetics, and owning antibiotic selection. I love ID. So it's so interesting now how my job has changed. And, during residency, I also at heart am an ambulatory care person. You can tell I want to talk, I want to teach. And so that is the right setting for somebody that has those attributes. And so for me to get to CF Clinic back in 2017 was really the right timeline to watch highly effective modulator therapy explode and be there for it and have a role. And, so I do want to talk a minute about, the CF pharmacy world, because when I started going back in the early 2000s, there were not more than a dozen pharmacists, amazing mentors. Hopefully they're hearing this now that, now there are over 300 pharmacists and pharmacy technicians that attend the North American Cystic Fibrosis Conference.
Wow.
We have new standards that are being developed. They're in draft and this is the standard of care. It's not just for pharmacy, but the standard of care for people with CF. And in draft form, we are no longer a recommended member of the care team. We have made a spot at the table and are now going to become a required member of the CF care team. So it's a beautiful trend that, those dozen pharmacists back in the day have just paved the way. And so a lot of places do have technician access. And I am just hooked that we have this dynamic duo. And I hope my technician never leaves me, because I am here to help educate and recommend therapies, and she is here for the access piece to it, because one thing we haven't talked with is how access to medication is such a problem, because they're costly, they require prior authorizations, and navigating that system, it's a burden to the other providers on the team, to the nurses on the team, and having this technician be able to get instant access. So, I had a late diagnosis. Real quick story. I had a late diagnosis last year. There was a 14-year-old who was receiving care at a neighboring hospital, and luckily came to us because her CT scan was, pretty poor. And so we were able to do a sweat test and diagnose cystic fibrosis. We were able to do genetic analysis and have triple therapy to her within 9 days. 9 days of finding out the diagnosis of CF, which I challenge anyone listening to text me and let me know you did better than 9 days. And that is all because of the pharmacy technician, dealing with the payer, dealing with any patient assistance programs that we need, whether it's grant funding or manufacturer assistance, and then making sure it's at the right, in quote, specialty pharmacy and getting it shipped out, to the patient quickly. So all of those levels of care are impacting adherence to therapy. And when you have somebody in the team that is owning that, like a pharmacy technician, it frees up your nurse, it frees up me, to be able to then spend care and time other places. It's amazing. So lots of pharmacy technicians in the world of CF. And there's a lot of other disorders, a lot of other diseases that I can think of that would benefit from having an advanced technician of the sort.
I feel like that's a very revolutionary thing to think about, but that's kind of like what we're doing here too. We have our care managers, and they're the ones that are freeing up our time and making it so that the pharmacists are really just performing at their highest ability, while the experts take their part, because I surely cannot do what our care managers do, and they get things done right away. So I love that you're doing that with pharmacy technicians. I guess a great way to close this episode out is just your career, Lisa, is just so cool and revolutionary. And I feel like you've really, really, really seen cystic fibrosis and the treatment of cystic fibrosis evolve so much, along with the profession of pharmacy, because now pharmacists are a required part of the care team. So cool. What's your best advice for our aspiring CF or just our aspiring clinical pharmacists out there?
I believe that my students definitely feel it in, their exposure and the way that I hopefully have even conveyed, without seeing me in the classroom. And so I really do hope that all schools of pharmacy do have some sort of touch point to a folk like myself, whether it's through experientials or not. Because I have several alumni now across the country who are in cystic fibrosis. They're not taking care of children. They're in the adult side. So that I thought was cool to see that even my experience in the classroom and getting them a little piece of knowledge about it, then throughout their training, they're like, oh, I learned a little bit about that, and then it could expand. And so I have several adult pharmacy practitioners out there with CF, that is great, because I'm so pro pediatrics that it's cool to even have extensions in other settings. And so I think that if somebody really wants to take a peek at CF, that we do have a mentor program that is set up, that it is really for CF centers. And so I am of the care model that you do need to be at a CF care center if you have cystic fibrosis. And so figuring out where those are, and then, trying to get your foot in the door there, and then definitely reaching out to our pharmacy network so that we can get you set up with a mentor, and come to the North American Cystic Fibrosis Conference, because it happens every fall. There's no better place to meet everyone.
Thank you. I mean, it's been a true pleasure. I am humbly and seriously what you've done in CF, mandating the pediatric the pharmacist to be a part of their care is truly what we're aspiring for over here at Perfecting Peds, which is any child that has medical complexities, they automatically legally mandate have to be partnered, just like you are with your pediatrician, with a pediatric pharmacist that's doing the medication management, just as our colleagues in BMT and CF have really pushed to have their presence. We can only hope to emulate, learn from you, and on a really serious note, seeing the success of the fellow pharmacists before us is what keeps me going and our team going every day, to know that it is possible. Okay, Lisa, so I think has been the theme throughout the show is probably, it feels like to you, it's taken forever to get the modulators and the right therapy in order to show, and really create the true difference and really impact the quality of life of these patients with cystic fibrosis. But in the snapshot of what you just went over in the timeline, it seems like everything's happened relatively fast. There's been a huge change in, which is most important, the quality of life of these patients. And so what is on the horizon for cystic fibrosis as far as medication management / therapies that will be available?
Yeah, no, I think where we're at today is de-escalating therapies, which who would have thought we'd ever get there? There was a study published called the Simplified trial, where we were able to withdraw some of that pulmonary therapy that I've talked about. So a lot of patients I have today may be on one nebulized agent, if any at all, and we're learning whether that's acceptable with real world data to be continued. So we do have to watch, because we are still just a few years out. With whether it's ivacaftor, we're at 5 years, or our triple therapy, we're at 3 years, but not even in the younger age groups, what real world data would look like. I think the biggest thing I'm most excited about is come January 2nd, 2025, the FDA will meet, and there's a new triple that should be available to us after that date. So it still has tezacaftor in it, but it has vanzacaftor, which it changes out one of the components of the triple, and whether or not it is more effective than our current one on market. We may see that in results. It claim to fame, though, is right now our current available therapies are twice a day, and this will become a once a day therapy thanks to deuterating the ivacaftor. And if there are chemistry people on here, I apologize that I, don't really understand what they did to the formulation to make it a once a day formulation. But what's cool about this is, again, it's going to be a once a day formulation. It may have greater improvements in that CFTR chloride transport, and it's going to come out for 6 years and above. So we don't have to wait. Historically, the other ones came out for 12 and above. The drug company went ahead and was smart and did the trial down to 6. And so we're going to hit the ground running and changing people over to this new therapy in 2025, I hope.
That's amazing. And that really sticks with the theme of the whole disease management, that it's getting younger and younger. And before we know it, I feel like I'm dating myself, but it was so obvious, even when you heard them talk with the CF patients that I used to take care of. And now, they're going to be run in the streets, literally, and have the most beautiful lung function and best quality of life. And it's a true testament to also other disease states that, like, the right research can really cause leaps and bounds in the entire healthcare system. So thank you for sharing everything with us. And we really appreciate your time.
That's all for today's episode. Thanks for listening. And remember to subscribe on Apple Podcasts and leave us a review.